Welcome to the Report Card with Nat Malkus, the education policy podcast from the American Enterprise Institute. Last week, New York City Mayor Bill de Blasio announced the city's 1.1 million school children would have to wait another 10 days to get back to classrooms, as purportedly unanswered questions about the feasibility and prudence of reopening schools prompted threats of a teacher strike. Well, New York stands out in being one of the only major school districts attempting a return in person this September. But the questions that teachers and parents are asking about in-person learning are being asked in districts around the country. Will our kids be safe if they return to classrooms? What about teachers? And what happens if a child or staff member contracts COVID? The answers to many of these questions are rarely straightforward. But with the stakes as high as they are, parents, teachers, and administrators need answers. One place they might find hints about what to expect for K-12 schools is in the childcare sector. Indeed, as K-12 schools have largely remained shuttered since March, many childcare and early learning centers around the country have continued in-person care. On this episode of the Report Card, I talk with Celia Sims about what's going on in the world of early childhood education and what lessons the sector might offer to K-12 stakeholders. Celia is the VP of Government Relations at Kindercare, one of the largest childcare and early childhood education providers in the world. Celia, thanks for coming on the Report Card.
Thank you so much for having me.
So before we get knee-deep into COVID, let's do a little table setting. For listeners who may not be familiar, can you tell me about Kindercare? What is it? How many kids do you serve? Where are you located? That sort of thing.
Sure. We are the largest, actually, private childcare provider in the U.S. Pre-COVID, I'll give you some numbers. We were serving usually on a daily basis around 185,000 children. We have locations in 40 states and the District of Columbia. We have been in business for, I guess it was last year, we celebrated our 50th anniversary. Interestingly, the company was originally founded in Montgomery, Alabama, and then somehow back in I think it was in the early 90s, found its headquarters moved across the country to Portland, Oregon. But said the company's been around for about 50 years. And the main brand that people know us best by is the Kindercare Learning Centers. If you see one of our older buildings, it tends to have this iconic red steeple that a lot of people have associated us with.
I remember it from my youth.
Yes. But we have two other brands. One is called Kindercare at Work, and that's where we do a direct partnership with an employer, either to do their on-site care or to work with that employer to provide care for their employees through our network of 1,500 Kindercare centers. And then we have another brand called Champions, where we have for years worked directly with public school districts and private schools to provide their before and after school programming on campus.
So to put this in context, Celia, you said that you had about 140,000 kids coming to Kindercare. And if you compare that to the largest school districts, that would put you in the top 150 school districts in terms of size in the United States. So this is a big operation.
Right. The difference we have between a school district is that our schools are spread across 40 states versus all in one geographic area.
Okay, so back in March, you're serving 140,000 kids. Before the pandemic was officially declared a pandemic, what was Kindercare's approach to the coronavirus? I mean, what was your initial reaction and what did the early planning conversations look like?
Right. So initially, as Corona was coming into being, we were taking our cues, as we always do, you start with CDC, public health officials, state officials. As you know, it's been, and I don't want to get into a discussion of who was right, who was wrong, but it's been a little confusing, some of the guidance.
I've heard that.
Over time. So we also have always had a large health and safety group at our company. So we were out, seeking guidance from individuals who were epidemiologists, who were emergency pediatricians. What is it that we can do? What was so stunning about the issue is that as this picked up, I said, like at March 9th, we were at 143,000 children. 2 weeks later, we were down to 13,000.
So was that because you closed a bunch of centers or did you just reduce capacity? What did that draw?
It was a combination. It initially was just parents pulling their children out. And that was because the schools shut down, office buildings started to close. And at that point, we had to make a decision. Do we try to keep our 1,500 centers open, all of them? Or do we try to get better strategic, knowing that we don't know how long this is going to last? People are doing different things. So we culled our number of centers from around 1,500 to a little over 400. And the ones we left open were ones that we mapped all of our centers to like within a 3-mile radius of healthcare centers as well as military installations. And that was how we pulled our number of centers. And we went down around like the end of March, around 450 centers.
And those centers were the ones that I'm assuming from your perspective, healthcare, military bases, we're talking essential personnel. You've got to stay open for that.
Right.
So what kind of timeline were you thinking on at this time? I mean, a lot of school districts were thinking, we're going to shut down for 2 weeks and we'll be back up and running in no time. Were you thinking short term at that point, or were you looking at the long term?
I mean, I think it was a combination. I mean, everyone was like kind of shooting in the dark. I mean, obviously for us to step down the number of centers we had, we knew it wasn't going to be just a 2-week process because, I mean, there are costs associated and we had to furlough thousands of teachers at that time. And, when you just reopen, you don't reopen a childcare center also on like at a moment's notice. You have to hire your staff back. And so I think it was more of a medium game. Now, like how many months? I think we all thought by now, as everyone in the country, that things would be moving along a little bit more fully than they are. But one thing we have always been is agile and ability to take new data, new information, adjust. And that is what we have continued to do. And today, all of our centers are open across the country.
And in what capacity?
In general, we're probably serving about 45-50% of our operating capacity. That can be very different. There are some centers that are almost back to normal. I would say those tend to be our centers where we've also, just for context for Kindercare, we serve a very wide socio-demographic of families. Going into this, about a third of our families were low-income working families. Centers that serve the higher concentration of those children have been at higher capacity because those tend to be families whose their jobs are not, you can't do them remote.
Right.
So you have to have care for your children during the day.
Yeah, I mean, that's a pretty interesting indicator all by itself. So over the 6 months that it's been since March, can you sort of sketch that arc? I mean, when was it that things started to lift out of the bottom of the trough in March, and how did it ramp up? Was it slow? Was it late summer? I'm just trying to get a sense of how it got back into shape.
Sure. I mean, like, as you know, the states reopened in a variety of fashions.
Indeed.
Jurisdictions open in a variety of fashions. So coming into, I would say, May, like we started ramping up or reopening centers. They did tend to reopen faster in the Sun Belt, so Texas, Florida, also the Midwest never did a full shutdown. The areas where it has been slowest to reopen has been the Northeast, which had much stricter shutdowns.
Right.
And even though there were at times like we would have probably felt comfortable opening, there were some states that by edict we were not allowed to reopen. Kentucky pretty much shut all of childcare down, and there were some other states in that bucket.
So I imagine you have a pretty clear pulse on the early childhood world. How would you say things are going on in the sector as a whole? And do you think the 45%, 50% capacity you're talking about is probably indicative of what we're seeing across the board?
From the data we've seen, and there is no straight clearinghouse, I think that's fairly indicative of where folks are. Again, any given center could be almost full or beyond full. And that is indicative. The lower number is indicative. Sometimes we are still under reduced operating capacity by local or state mandate. And some of it is, parents they are not yet ready to return. And that's a combination of they may be uncomfortable, they may have lost a job and can't afford, or have no, like at the moment, don't have a need because one spouse is not working any longer, or they're just kind of continuing to do what they've been doing the last couple of months and not trying to rock the boat, particularly if they've got school age children. We've heard that, like, I'm not ready to kind of readjust the schedule until I know what K-12's doing because the family has just emotionally gotten settled and change is hard.
Sure. So, Celia, not too long ago, I rang you up and said, hey, help me understand some of these numbers I'm seeing. And I'm going to quote you some of these. From California, they have some state tracking of the number of cases that have come out of childcare centers and family run childcare centers. There's a lot more family run. What they're reporting as of August 23rd, this is 2 weeks ago, they have almost 34,000 centers open in California. Almost 9,000 are centers, non-family run. Out of that, they have less than 2,100 cases for children, staff, and parents, and less than 448 cases for kids.
Yeah.
And I came to you and said, this is eye-popping to me. This suggests to me that the transmission rate in California childcare centers is pretty low. It is much less than I would expect, especially given all the concerns that I've heard about bringing elementary school students back or students back in general. Now, obviously, it's apples and oranges to some degree, but they're still in the same fruit basket, right? I mean, they're not totally unrelated. So when I asked you that, can you, and we put this out there for our listeners, can you help put that into context? I mean, are the transmission rates extremely low? How much of a comparison should we make? And how high a quality is this data? What should we make of it?
Yeah, so let me start with the data. I've got a lot of questions about some of the state data. It is messy. I think California's is fairly messy. Texas is fairly messy. But there have been some states that have been much cleaner on their data and much more methodical, like North Carolina and in Oregon. And in general, I would say the transmission rates that we've seen, where I think the data are good, and we are very much at Kindercare tracking our own transmission rates in comparison to states. It has been fairly low. Like Kindercare, like our transmission rate, it's a fifth of what the state rate is. That I would say for Kindercare and for the high quality childcare providers in general is very attributable to the health and safety practices we have had in place from the beginning and that have adjusted up over time on this. But in general, the transmission rates do appear to be low. We follow very carefully directives from state and local health officials, like when there is a case, and there have been cases. If you find any multi-site provider out there who says they've not had a case, I would be skeptical because it's when you have a case in a childcare center day, it's not necessarily a indication that provider has done something wrong. I mean, this virus is in the community. Our staff, our families, our children do not live in a bubble in our center. So invariably, someone is going to be exposed on the outside.
Absolutely. So I imagine, and I'm sure you're not dishing on the small family centers because I'm sure they're doing practices too, but they're probably not as institutionalized as the large practices. But again, when you look at these numbers, at least the ones from California, which break out the private family care centers, again, we're just seeing pretty low numbers. Now, if those numbers are tracking low, what should somebody like me who's just watching school reopening plans and trying to figure out whether we are accurately assessing the risk of sending students back to school, what assertions might we make from this data about K-12 schools? And even if we limit it to elementary schools, certainly they could both take some of the same measures to protect students. Undoubtedly they will. But we got a lot of closed elementary schools out there. And I certainly don't want to grasp onto a hope that, hey, it's easy, let's walk right into the lion's mouth. But neither do I want to sit back and ignore evidence that really sort of makes me think we should be sending kids back to school more frequently than we are.
Yeah, I mean, I think the safest assertion is, yes, I think it can be done. Nothing is risk-free, but it can be done safely. Again, knowing that there's going to be cases, but it takes very thoughtful planning. It takes thoughtful training. It takes very thoughtful and transparent communication to make this all work. And so, we have had at Kindercare and other providers who stayed open through it. I mean, we have been at this with COVID-19 protocols from March. I mean, our protocols have evolved over that. We have learned more. We've adjusted some things we used to do. We don't do some things we didn't do. We now do, but it has been an evolutionary stage. I know that things will continue to change, but it, again, as I said earlier, like when we went from going down to like 400 some centers back to 1,500, we didn't open them overnight either. And even when states were reopening, we had very thoughtful plans about like how do you bring your staff back, how do you train them, what are the protocols. So I do think it is possible, but it takes a lot of these early steps of the thoughtful planning, the thoughtful training, and really clear communication to your families, your staff, and others. How you're going to respond when inevitably a case does occur.
Let me ask you about the two sectors, sort of the childcare sector versus the K-12 sector, in terms of just their outlook and their base of operations pre-COVID on looking out for the public health needs of their students. And the reason I ask is because oftentimes when we think of really young kids, we're really concerned about vaccinations. We're concerned about transmission of diseases when kids are little and perhaps more susceptible. I mean, you have heard what many teachers have said, that classrooms are like petri dishes. I'm sure it's the same thing for early learning centers. Is there a difference in the roles that childcare centers have played when it comes to public health and the role K-12 schools assume?
Right. So I think the biggest difference is historically, childcare has been regulated almost primarily from the beginning from a health and safety perspective. That is very different than K-12. I mean, we are inspected constantly from a health and safety. I mean, some states, health and safety inspections happen 4 times a year, and sometimes it's more often, but like it is just always, it has evolved as health and safety being the primary concern and check on, do you have a quality provider or not? Now, health and safety does not in and of itself, you could be the cleanest and safest place, does not mean you would give a quality interaction between the adult and the child. But without basic health and safety and childcare setting, none of this other stuff could really occur. So we have a history of that K-12 does not. And I'm not saying that K-12 are dirty and like they don't know how to do things, but their teachers are not trained on how do you work with young children to wash their hands. Childcare is all about, like, we have been talking and teaching hand washing forever. It's a second nature. We know how to make it fun. We also know, because, in childcare settings, particularly with various children at various levels of, immunization schedules and whatnot, we are attuned to outbreaks. Not that they happen frequently, but they have happened, over time historically. So we've always had interactions with public health officials about an outbreak and, how you handle that and how you take your cues from public health officials. And it's just it is a very different construct that K-12 really came out from. You start with the education and maybe the health and safety is somewhere in there. And childcare starts with health and safety. And now over time, we've started adding, which I think is a good thing, educational and other quality standards.
Right. So back to the records that have been tracking, you said that the California data was fairly loose, and indeed it is loose. I mean, the counts that they're putting out are sort of cases, not necessarily defined very well, and then centers. So you don't really have the number of children in the centers, right? So you can't actually figure out what the case rate is out of. And to somebody like me, who is, again, sort of concerned both with childcare, but also with K-12 reopenings, I'd really like to have a little bit better handle on that data, right? The better data you have, the more you can actually sort of follow the science in terms of reopening.
Mm-hmm.
It seems to me that we're a little bit hamstrung to follow that science because we can't look at other places that might be indicative of what we might expect if we reopen public schools. So having said that, what kind of data does get collected, and and I know that you're not a data expert, but I'm just curious as to what kind of data we would have wanted collected by these states to give us a good angle that could inform school reopening decisions.
Sure. So I would say in every state in which we operate, we are required, if there is a positive case or presumed, to report to public health. But that's where it kind of has stopped in a lot of states on the data. And then there have been, I would say, the state that stands out to me at both on collection and reporting of data for childcare and K-12 is North Carolina. They have been, since the outset of this, been reporting not just the center, the number of cases, but they've been looking at clusters where there have been clusters that are associated in a particular setting. And to me, that is the most important data to be looking at in any type of congregate setting. I mean, as we talked about, there's always going to be an individual here or there who's going to have exposure somewhere.
Right.
The question is, what's happening in that childcare setting? What's happening in that school setting? Or now we should, I think, then you're asking what's happening on that college campus. And are there things, if you start to see large numbers in a congregate setting, that is probably indicative of a breakdown or a need to tighten up. I mean, it could also be you've got a familial unit in there, but you need to look at it. And so like North Carolina and Oregon is also doing this on a weekly basis, published data in childcare settings where there has been 5 or more related cases. And that's public health officials doing the contact tracing saying, hey, these 5 or more cases, both of staff and or children, seem to be associated in that setting. And that to me is the important data, which California is not doing and Texas is not doing. And I think we talked earlier, I had a somewhat, I found, wild conversation with Texas because they were reporting to the press numbers similar to California. We've had this number of, cases, but it was not associated with clusters. And so I emailed the state and I said, I said, I keep seeing you giving data to the press. Where are the data on your website? Oh, it's not on our website, but if you call us, we'll give you the numbers. Said, well, it might be nice from you can report data to the press to actually make it easily available. And then I said, do you have plans to look at these data via a cluster model? And they said, we just don't have the capability.
So the distinction you're making is, hey, you can have cases and those can just sort of stem from we are not impervious to the community which we are in. There is COVID in the community. There will inevitably be some cases associated with our center. Okay. The cluster is when we have a center and we have a bunch of cases, much more dense than you would find in the population. And that is an area of concern because it suggests that the center is actually spreading COVID. And this seems to me to be the concern that we have about schools. I mean, certainly we are seeing this in colleges, right? Colleges are returning and then, wow, their case rates really go up. Where? At that school. That's a problem. But the consumer of information about these cases, in order to actually read what's going on, needs to be able to distinguish between, well, that Kindercare center had a case of COVID, I heard, and there was a cluster at that Kindercare center. And I'm sympathetic with state health departments that are probably dealing with a rather long to-do list. Nonetheless, this seems like a pretty important distinction to make to provide information to K-12 schools as they're opening up. And what you're saying, it seems like, is the minority of states are providing that service.
From what I have seen, I have not seen many states, with the exception of a few, really looking at this from the cluster perspective. I mean, states, I think where they have been concentrating on their efforts on the cluster data have been at long-term health facilities and nursing homes. We all, I think, can agree that was a necessity. But it was interesting. I was listening to another podcast not too long ago with John Barry, who wrote the book on influenza several years ago. But the one thing he said about the 1918 outbreak, and I think I have seen, just watching this, is it's the lack of transparency that really starts to weigh on people because they don't know. And when you don't know, you start to make your own, you can make whatever theory you want out of it. And I think it's just so much better to be upfront about like what your policies are, like to collect the data and then be upfront, like when this happens, this is how we will respond in concert with public health officials. But like, when we have one case and it's restricted to a center, sometimes the public health officials tell us to close down for 72 hours, do a deep clean. We clearly communicate that with the parents. And that has, we've had a number of 72-hour closures over this period of time, and we've deep cleaned. But sometimes we have had, so those larger, we had this much earlier, those larger outbreaks of 5 or more that necessitate us to close for 14 days. And in that time, of that 14 days, we also retrained all of our staff. And one thing I would say that we have learned, which I think we have seen why we now don't have many clusters, not to say that we won't, we hope not, but it's more one-off cases, is our very much adherence to what the term was coming up in early childhood before K-12 took it over, the pod structure. And we do think, and we've heard this from epidemiologists and other public health officials, it is the number one thing that we are doing in our childcare centers at Kindercare. I know other providers are doing it as well, and that we are keeping the same group of children and staff together throughout the day. And that way, if there is ever a case, you are restricting the number of people possibly exposed. And that has been critical. And we've done, I think, a really good job communicating that pod structure to our parents and why it's important. But we have seen that very much keep us down on the number of clusters.
And that pod structure, what I understand that to be, is simply that instead of having a large Kindercare center with mixing of everyone in the center, you partitioned it into particular rooms, and the children in those rooms don't mix with the other rooms, and that breaks down the probability of transmission.
Right. And then we've got other, procedures in place in that, parents don't come into classrooms anymore, and they understand why, because we need to, again, reduce the number of interactions in a given day.
Let me ask you a little bit about how you negotiate competition. Kindercare is a private provider, and there's precautions that you have to take for safety and to manage the virus, to close, to reopen at a deliberate pace during the pandemic. On the other hand, you got a bunch of parents that need to work, and I'm sure you got plenty of demand. And so to some degree, I think there may be a concern here that for childcare centers that want to maximize the number of families that they can serve, that's better for their bottom line. There's nothing wrong with that, as long as it's balanced with, precautions. How would you describe sort of the presence of competition during COVID? Are you getting a lot of transfers when you open up ahead of other areas? Is it managed such that the entire system sort of comes back at the same time, or does that vary across states?
It really does vary. I mean, I said we've got, parents are coming back on different schedules. We have picked up parents who were not Kindercare parents prior. A number of them, that is because their former center did not reopen. There are a number of childcare centers that have not reopened. It could be a change in the work schedule. I mean, there's a whole multitude, but we have been, like Kentucky just the other day, they were one of the most restrictive through COVID. They just lifted the group size, or raised the group size that you could have in any given group. And Ohio was slower on that. Massachusetts has been, slower on that. And particularly in Ohio and Kentucky, and we've had it in other states as well, when we were capped at, maybe you used to be able to have 15 in a room, but now you can only have 6 in a room. We did have parents, like on the wait list calling, like, I've got to find someplace. Because as we've talked, I mean, there are a lot of jobs that you cannot do them remotely.
Right.
And parents need a safe place to take their child during the day.
A lot of time over the past 6 months has undoubtedly been spent solely on COVID and preparing to return. So when there's thousands of school administrators bringing kids back, many are remote, but a lot are bringing kids back, and I'm sure they're up at night worrying about it. What advice would you give to those administrators as they start another school year?
I mean, I think as we've talked already, I mean, the top three things are planning for health and safety, which is for a lot of K-12 is a new thing. And, there are lots of childcare providers in your community. They could be a good resource to actually ask, what are the types of things you've done? Where have you seen, where you've had to adjust your operations? And then I think has to be a lot of deliberate training and outreach to teachers on health and safety, not just what they need to do, but what is also being done to keep that school setting as clean and safe as is possible. And then also very clear communication plans on, if and when there's a case, these are the procedures we take. We take our cues from the public health officials. This is what you might expect to happen. Again, clear articulation of how that's going to be reported to the public. I think one other thing I've noticed too is, I think you and I talked about it, and I haven't seen as much up for K-12, but higher ed's been really, I think, fascinating to watch in this. So it's the beginning of some of this coming back, throwing out FERPA and HIPAA as reasons why they could not initially be transparent on the number of cases on their campus, which is just a bunch of baloney.
Those are laws about privacy concerns.
Privacy, right. And again, like when we talk about, reveal to our parents that we've had a case or not, we do not reveal an individual person's name.
Right.
You would never do that, but you do have to be transparent about what has happened, what you're going to do and your cleaning protocol, and how you plan to reopen. And everyone needs that to feel comfortable about, what decision they're making.
Yeah, a lack of transparency on this point may not do much for parent confidence.
No, not at all.
Well, Celia, thanks for coming on the report card and talking to us. And we wish the best for Kindercare and the thousands of kids that you're taking care of every day.
Thank you so much for having me. It's been a pleasure.
Thanks for listening to the report card with Nat Malkus. And special thanks to our guest, Celia Sims. I also want to thank our producers. They make this podcast possible. That includes Matt Rice and Tyler Hoover. You can subscribe to the report card on iTunes, Spotify, or wherever you get your podcasts. And while you're there, take a minute to leave us a review so other folks can find the show. You can send comments, questions, or topic suggestions to ed.podcast@aei.org. That's all for this episode. I'm Nat Malkus.